but it's good to finally be able to start this. My name is Chika, and I work with the EAF team, and I'll be discussing with you on this panel about the logistics of universal health coverage. Before we kick off, I'd just like to obviously welcome everyone from around the world watching this. So hello, everyone watching us from around the world. Welcome to this panel on the logistics of universal health coverage. I am Chika Jones with the Engage Africa Foundation team. And this year's festival is incredibly exciting because we're delving into the work involved in mobilizing for a healthy Africa. And special thanks to our guest, Margaret Mutumba, the co-founder of MedAtlas, which is a startup that makes it easier to bridge the talent gap and to find specialist doctors in Africa. Thank you very much, Margaret, for making yourself available, given the scale of the work you do. I'm supremely happy and glad that you're able to carve out the time for this. Thank you very much for making it. So let's jump right into it, right? We're going to be starting on familiar ground and talking about the work MedAtlas do and the work you do. And then eventually we delve into the larger questions of universal health coverage. So I guess the first question I have here is, from what we know about health coverage, both in Africa and outside, one of the major, I would say, issues that people face is the financial resources to be able to access healthcare. So for MedAtlas, how did you approach pricing and payment for the specialists on the platform? What were some of the things you thought about in creating the model you currently use?
Great question, Chika, and it's a pleasure to be here once again. So just to set the context, MedAtlas is focusing on specialist healthcare. And when you think about specialist healthcare in our African setting, it's the hardest to find. So we have done a good job of building infrastructure to provide access to primary healthcare, which is very important because of course, the impact of those conditions is very wide. So we have done a good job in that. However, as a continent or as a people, our lifestyle and the changes we're experiencing are leading us from more communicable now to non-communicable diseases. So we're seeing rises in diabetes, rises in cancers, mental health, of course, now is also a very huge issue, addiction. And so these are conditions that we have not yet set up our general, should I say, public health infrastructure for. So the specialists that are available to address these conditions are fewer. Oftentimes this training has to be done abroad because locally the training to address these conditions is not there. So that means that as a specialist, first of all, on their side, they're making a huge investment to acquire the knowledge and the expertise to then come back on the continent to provide that service. If they do, we have a high rate of brain drain. So many of them don't come back anyway because they're paid better. The same thing happens now on the population side where people don't understand these conditions well enough. And so they don't know who to go to. And most times there's fraudulent health practitioners who take advantage of our lack of knowledge in these spaces. So in terms how that leads into our pricing is that we gave our specialists the leeway to quote the fees that makes the most sense for them. Because obviously they've gone a long way to educate themselves and be able to be experts in these areas. They are aware of the context that they're in. Many of our specialists are from Africa or understand the African context well enough. So they're not disillusioned as to the financial barriers that we face. But then you have to find a balance where there's an incentive for them to be on the platform. It needs to also make business sense for them. Having said that, when you compare that to, for instance, if the services in another country, as a patient, I am saving money through travel, having to book accommodation and so on. So at the end of the day, it's still cheaper than the alternative.
That makes quite a lot of sense. I think that that's a clear, and I think it also makes sense when you think about it from a sustainability angle. There's only so much you can do for free in quote, for example, here, because obviously investment, like you said, has gone into learning, into acquiring the knowledge, into preparing the resources for the specialists. Thank you so much for that clear answer. And this obviously goes straight into something we're thinking about on a larger scale. So for some countries, right, the way they approach universal health coverage is we have obviously the single payer system, we have socialized medicine, and we also have private health insurance. Now, from your knowledge, right, which of these do you think makes sense for countries to adopt? Because, for example, if we go from outside in, the UK uses socialized medicine, which is obviously a case where while people can pay obviously as part of their taxes for healthcare, the most hospitals are still publicly owned. And what this means obviously is that doctors and nurses are employees of the government, they're public health workers essentially. While for those who go with the single payer system, it's still similar, but it's just that most hospitals are privately held. So in places like Kenya, for example, and I was preparing for this session, I was going through some numbers, and South Africa, Tunisia, and Kenya have some of the best health coverage in Africa. And a lot of them, while they largely rely on private health insurance, some of these countries are already piloting on a small scale the single payer system where the government pays for it while hospitals are still privately held. So among these three kind of structures being put in place to help with health coverage, which do you think makes sense, at least on a macro level, for countries? And obviously you can take your answer, tailor it specifically to the country you're in, but generally, what system do you think makes sense?
That's a very expansive question,
Yeah.
because a lot of the capability to provide these different levels or tiers of healthcare depends on the country's ability to track all their citizens, right? That system has to be in place. Now, in many, I would say, African countries, there's a huge informal sector that makes revenue and does not necessarily pay taxes because they don't fit into the formal government structure. So if you're in a context where you are not yet at the level where you have good knowledge of all your citizens, where they are, what they're doing, how much they're making, and infrastructure to be able to collect taxes from them, that the way the UK does it is not practical. And Europe is able to provide that universal healthcare because they know every individual that's within their country, right? They have very good regulations around that. So for us to be able to do that, which is the ideal, to be honest, we would have to set up our infrastructure to be able to track all our citizens and make sure that we're collecting taxes from them fairly, of course, to be then to sustainably fund these systems. Another issue that we have to be frank with is corruption. We've had many of these socialist systems come into play, but the funds are not used appropriately. And so that discourages, it depends on the trust level that countries have with their leadership. And so that would discourage populations to paying into these sorts of national funds because they are not well managed. However, that would have been the ideal. Having said that, I would speak, for instance, I'm now based in Canada. A bit of both maybe is a good idea. So in Canada, we do have the sort of universal healthcare coverage for basic things. But when you start going into more complicated procedures that are more expensive, then people have to get their own private insurance for that. So things which are considered non-essential, like dentistry. Personally, I feel that's essential, but every country determines what that means for them, right? And also there are some patients who just want a better quality of care. Sometimes, especially in Africa, public health systems many times don't have a good reputation in terms of quality of care and timely care. So you need to give patients the option, for those who can, to then be able to access care in maybe the private sector, maybe just to top up on the basic packages, to then be able to receive a higher quality of care. But I think fundamentally, what will determine what's possible is the ability to track your constituents in whatever country you are, and the trust that those constituents have in your ability to manage those funds well to improve healthcare. Many African countries, historically speaking, do not prioritize health. They prioritize maybe their armies, and there's larger investments in maybe financial development. So normally health is not seen as a core priority. So there has to be, even on a policy level, incentive and buy-in to then be able to invest and adequately use funds to improve healthcare for all.
Thank you very much for that clear answer. And I totally agree with you, especially on the part of, obviously, we have to put the horse before the cart, which is, first of all, data. Like you said, we need to know who is who before we can even start thinking of how do we go about taxing them, and how do we go about creating a healthcare that actually fits their needs. And then obviously the trust level, because when you start from data, and then when you tell people there's a healthcare system, if, for example, like you said, they can clearly see the poor quality being delivered in the public health sector, they are less likely to bring out funds for that. I think most of them would just prefer to go private, which makes sense. So data, like you said, and somehow working on the trust level will be very essential. And what you said, I think, is clearly the problem, because in most countries, what's been done is, or at least what's been done by people like you with MedAtlas, is going micro, which is while we wait, obviously, for the government to set up the right structure, to gather the right data, to create the right system that can build that trust. Let's start from somewhere. And that's what MedAtlas is doing, which is starting by improving specialists, giving specialists access to I guess, a consistency of people who need their services. In Kenya, for example, the community health system is like really key. One of the research I did showed that there are about 36 remote underserved communities that have been served by four-wheel drive bicycles, by vehicles, by bicycles, by camels, and people just walking into these communities to provide healthcare. There's this example I read of in South Africa called the Unjani Clinic in a Box, which is essentially, when I think of it as kind of like Uber for healthcare. So Black women who are nurses or have the prerequisite medical training get the funding to set up these clinics in their communities. Over a period of 5 years, they pay back about $30,000. But what it means is you can bring the right healthcare to communities and empower women at the same time. And what that also means is healthcare that people would normally not have access to, they're able to have access to it, because the setup is, it's a mobile clinic essentially. So you don't have to think of the cost of renting, buying land or renting a huge space. You can set it up mobile in a trailer and start serving a community, which is really good. So I'm thinking around that, and I'm thinking about ways that we can work can start on a micro level, while we obviously wait for the larger questions to be answered. So I'm sure that, and I'm assuming here obviously also that in your process of coming up with your startup and doing your work, you have encountered some of these models, models being created by entrepreneurs like you on a small level. Are there other ones you want to talk about that you found really interesting that you think other countries, I'm Nigerian, so I can give Nigeria as an example, other countries that like Nigeria can adopt on a micro level while we wait for, obviously, like I said, the big things to happen on the government end? Are there some you'd like to share?
Yes, and first of all, that's a good point that you bring up on a micro level. And I just want to say, from my point of view, I think that is more sustainable, because whilst we're talking about governments change a lot. And with those changes means priorities are also changing. So in terms of continuity of care or projects or agendas and policies, there's often that breakdown depending on now which leader has come up. So that turnover creates a barrier in terms of sustainability. But when you look at the micro level, what I like about the examples you've provided is that one, probably most likely these people are from those communities, so they have good cultural and contextual understanding of the communities that they are working in. They probably have personal passion and incentive for working in these communities. If you've noticed in public hospitals, at least for most of the African countries I've visited, they said that the healthcare practitioners are normally quite rude. They're quite overwhelmed. There's language barriers for people who are coming from different parts of the world. And so building hospitals was a Western way of addressing health. In African culture, things were always done in communities. And so I'm happy that we are reverting back to taking healthcare into the communities. And some of the innovations that I've seen in this area, I'm in the digital space, so of course, many of them include that. But given that we have grown to use mobile money, a lot of people have access to phones and USSD. So I've seen some projects where folks can use some USSD codes to contact nurses when they want to give birth or when they just want some nursing advice. And I think nurses and community healthcare workers are the best option because they're greater in number in comparison to doctors or specialists. And so they in terms of access, they're easier to reach, and they're probably the most diverse group of healthcare workers that we have. So I've also seen other projects where they're training youth, for instance, in sexual and reproductive health. In African culture, we have stigma around talking about sex and, sexual diseases and that sort of thing. So instead of putting the burden of healthcare practitioners to do that, kind of leveraging youth and communities to be able to communicate to their peers, because that's where a lot of their learning is taking place. So I think it depends, each country has a different cultural setup. And I think moving forward, what we need to do is understand the culture, because even with Nigeria, I'm sure there's lots of many cultures. We can't even necessarily speak on a country context, because even within the country, there's going to be many different cultures that address things a certain way. And we need to communicate health in the language that those people understand, and not force individuals to learn all this medical jargon just so they can receive their health care.
Very true. I think I really appreciate that closing point around kind of building from a culture-based perspective instead of going from outside in, you go from inside kind of out, because then the cultural and language barriers are easily overcome. You mentioned something which actually goes into the next question I have, and it's around tech. So I would like to say that with the increasing penetration of internet and technology in Africa, we've seen quite a lot of improvements in how healthcare is delivered. Telemedicine has become something really huge. And you also obviously mentioned USSD and every other thing. So, and the question is a bit broad in that when you look at the healthcare over the past, say, 10 years, in Africa specifically, how do you think tech has helped? What are some trends you've noticed? And also, in what ways has tech also caused issues? Because I know, for example, during the very height of the pandemic, I'd like to say, false information, misinformation via social media was a big issue. So we do have some people saying tech is a problem in some ways. So I'd like you to just speak a bit about that.
That's great. When we look maybe back 10 years, tech was mostly used or funded for healthcare information systems. So a lot of international funding, again, back to your point around the importance of having data to make informed decisions. So I would say that that's when I personally saw growth in use of technology and softwares to make healthcare information. And that was mainly in government health systems. And I think that's going to continue for the foreseeable future. For your private practitioner or clinician, um, there was hesitancy from what I saw. Many physicians or clinicians are very happy with their pen and paper and not very much interested in using technology. And that makes sense, because if you have power outages all the time, or if you, for some reason or another, can no longer afford to pay for a healthcare system which is holding all your patients' information and so on, or if it's cybersecurity is a very big issue for us in Africa. Those are all still major issues. So it makes sense why in some spaces there's hesitancy to engage in technology, because we still have a lot of work to do to make it safe, as you've talked about with misinformation. But when people now start sharing their very sensitive healthcare data online, and they're using, for instance, an internet cafe, not sure of the quality of security, there's risks associated with that. But what I have seen practitioners do is use WhatsApp more and more to engage with their patients. And so even with technology, sometimes you don't have to reinvent the wheel. People are already using WhatsApp. I know on Facebook and social media, there's a lot of patient groups that come together to discuss whatever that the condition is, and bring in specialists to talk to their communities. So what that does is that, one, for some diseases, it was a very lonely journey, because if someone else didn't have it that you knew, you suffered alone. But for certain conditions like infertility, where I spend most of my time, it means that people who are going through stigmatized conditions are able to build communities online and talk about different things that might be challenges to them, and also get the support they need. On the other hand, and this comes back to digital literacy, we have a long way to go in terms of digital literacy. Just because something's on the internet doesn't mean it's true. And so for folks to be able to discern that is going to be a bigger challenge. We have lost, people are no longer interested in hearing just from WHO and, all these major healthcare entities. And of course, with the pandemic, many people were not very happy about how some of these major institutions handled it. So now we really need to think about how to offer credible information online. For instance, right now, our opinion leaders used to be, back in the day, politicians or doctors. Right now, they're influencers, right? An influencer can go and speak on a health issue, and people will take it as gospel truth, because now everyone has a platform to be able to easily communicate their ideas. So I think moving forward, that's going to be a challenge globally for sure. Of course, locally as well, that's going to be a challenge that we need to think about. So educating our folks about digital literacy, educating them about being able to discern what is authentic, what's not authentic. I know here in North America, they're talking about augmentation, where someone can use me right now and change the words that I'm saying, and you won't be able to know whether that's authentic or not. So it's a very dangerous space that we are getting into. And so we need to, fortunately, Africa, we have not yet advanced. And I think we have the benefit of learning from other countries and seeing what worked and what didn't, and making sure that we put those restrictions in place to protect our people.
Thank you very much for that clear answer. And I think it's like you said, expands into a bigger question around trust, like who can we trust? Because the pandemic, mostly because I think it's unprecedented, led to a lot of gaffes from people who were supposed to trust. And now everyone is kind of like on the back foot, not sure who to trust. But I think I'll have a later question for you on the question of trust as a whole within the healthcare system. And maybe we can delve a bit more into that. But let's come back a bit to MedAtlas and the work you do with it. How do you ensure quality control on the platform? I think it's kind of linked to what the discussion we're having around building a community of specialists, for example, that people can trust? Are there systems you have in place for that? Are there ways you go about ensuring that the right kind of specialists are available on the platform and they're doing the right things?
Yes. So as far as we at MedAtlas, we do our due diligence on all the specialists that we are engaging with our platform. Due diligence means that many countries have medical associations where all practitioners have to get their licenses, and that's done annually. So for every practitioner that's on our platform, we have that information with their medical qualifications and their practicing license to show that. We also prefer going through recommendations. So many specialists know their peers who are doing a good job in the space, and so they recommend them, and that's for us another way of ensuring quality control. At the end of the day, even with specialists, while they have knowledge, we do invite our users to exercise their voice. So that's part of what we're doing with MedAtlas, is that because in African culture, we have this thing around respecting people who know more, or our elders, it leads to many patients being disgruntled because they don't feel they're empowered to ask the right questions from their specialists. Sometimes, especially with rare diseases, when a specialist is giving treatment options, they're just giving suggestions. We can try this, we can try this, we can try that, especially in specialist healthcare. So what we're doing with our patients is we're encouraging them and teaching them how to ask the right questions and know that it's your money. You're paying for this service. So if you have not adequately understood an issue, or if you're concerned, say that, and ask for that help. Because whilst we know that educationally the specialists have the knowledge, in terms of how they offer their service, that's at their discretion. Not everyone offers their services at the same quality. They might have the knowledge, but the quality of care is different. And in some ways, it's your role as a patient to make sure that you get value out of that interaction, and a bit of background education as to what you're going into. And of course, we tell them at the end of the day, we are a resource to help you find these specialists, but we cannot guarantee the outcomes you want. I'll give you an example. For instance, in fertility, if you go through IVF, the chances of becoming pregnant are 25%. 25%. No matter what a doctor does, they might do all the right steps, but there's an element of the unknown. And so the average success rate is 25%. So if you empower a patient to let them know that, look, you're going into this process, and yes, the clinician is going to do the best they can, but the outcomes are just 25%, then they're better prepared for the outcome. However, patients who are not will say, I paid all my money. You told me this was the best specialist, and the outcome has not been positive. So a lot of that is just educating people that while these are specialists, they're not gods. A certain part of what they do is to create the right environments for you maybe to get better or to get the kind of care that you need. But on a certain level, they also cannot do God's work, to be honest. So just balancing expectations and making sure that everyone on our platform is qualified to do what they say they're doing.
I think that was quite succinctly put. I think, and just to maybe recap for our viewers at home, we've obviously discussed clearly I think the crux of the matter, which is that for most African countries to get to the point where we are proud of the kind of healthcare coverage we have for every citizen, we have to start from the beginning, which is getting data so that we can make the right decisions and put into place the right structure for universal health coverage. Something else Margaret has made clear to us is culture is important, obviously, which is that we can't always kind of talk down to the people we're trying to care for. It has to be talk with them, know what they want, understand where they're coming from, and create the kind of proper healthcare structure that can help them. And I think in our more recent questions, the question of trust has come up quite a bit, which is what you touched on, Margaret, which is that, for example, at MedAtlas, in providing healthcare, patients are also educated to know what to expect, because if we use the example, obviously, of the pandemic, which we've spoken about, one of the reasons I think was fear. Obviously, there was the fear of, obviously, it was quite contagious. And so people put into place a lot of, I will get systems that they felt could help with that. And while a lot of it was obviously the right decision to make, knowing that people could still get the virus despite all those I would say all those steps put into place made people a bit wary because they felt like they had done everything that should be done, and yet this is happening. So that trust was kind of lost there. And I think that's why I like the point you've made on it's 25% is the best that you can do. We'll do everything that's possible, but please also know this, because once people are armed with information and expectations are properly managed, they are less likely to feel like their trust has been broken. And thank you very much for expanding on that point. Something else I would like us to talk about, and there are a couple of questions I have, so I'm trying to prioritize them. I think the one we should go into is clearly starting up, obviously, because I also think of MedAtlas as a startup or a scale up at this point, because it is growing quite rapidly, and good work on that. How did you handle funding and starting up? And is it an idea? And I've noticed this with a lot of entrepreneurs. Most of them have had the idea forever in their heads. It's been 20 years in the making before it comes to life. So how was it for you? Has it always been there? Was it something you just thought of recently? And how did you go about starting up and funding?
Thank you, Chika. So I guess just to put some context, my background is in public health. So I have always been interested in health systems and how health systems can improve the wellness of people on a large scale. While I appreciate what specialists do, I was more interested in what I thought was greater impact for the greater good. So I've been in the public health sector for about 15 years, and studying and watching how different systems work. And so in terms of coming up with the startup, first of all, I had no intentions of being an entrepreneur. I'm a very much a science, very structured person, get my job and that sort of thing. I'm currently completing my PhD. So it came to me by surprise, let me put it that way. I'm at the University of Waterloo, which is very famous for innovation. And so for me, becoming or starting MedAtlas was by osmosis. I was just surrounded by people who were innovating, thinking about ways of solving problems, out of the box ways of solving problems. And they have built the infrastructure here to support innovators. And so what I love about what's happening in the African continent is right now we're building ecosystems and we're encouraging young people to innovate and come up with ideas. However, of course, with the knowledge and mentorship, at the end of the day, you need money to support an innovation to test it out, right? And so for me, I'm in the infrastructure where that funding is made available. A lot of universities, and that's why if there are any innovators here on the call and you're in university, it's normally easier to innovate in university because funding is normally easier to get a hold of. Sometimes you need some sort of expert as well to come in and guide that innovation to convince maybe investors to invest in it. So institutions like universities and incubators and accelerators are great spaces to innovate. Of course, keep in mind intellectual property. And so if you're innovating, make sure that you know who owns what. I think that's one of the biggest challenges. But yes, I was fortunate to be in this system, but I was also fortunate to have networks back home in Africa, having worked with many clinicians to test with, right? So it was much easier to get it off the ground. Of course, if you're starting from zero, they're going to have a longer window where you're doing customer discovery and research. And that's very critical because you don't want to build something that no one else wants. At the end of the day, you've spent money, you've spent time and resources. So sometimes it's inside knowledge you have. So what's your unique value proposition, right? Is it that you understand the space? Is it that the issue you're addressing has personally impacted you? And so you know how to solve it. So just think about what's your strength in going into whatever innovation it is, and then find the community of support. You have to be proactive about that. Even with me being in Canada, the truth was most of the mentors here are Canadian, and I am solving an African problem, right? So there's the having to help them understand what that problem is. And so I also had to be proactive in finding communities, African entrepreneurs who understood well the kind of challenges that we might face on the continent to help me think through our ideas. However, of course, when it comes to funding, um, this part of the world is very supportive in that way. But I think that's changing. A lot of investors now see the potential in Africa. To be honest, we're going to be the largest population, I understand, by 2050. So the economic opportunities in Africa are quite wide. So I think now it's moving beyond having to be in North America. I think now investors are actually coming to the continent. And I think that is going to be a trend that will work in our favor in the coming years.
That's really insightful. Thanks for sharing that. And I think so. I think four things have actually come out clearly in our conversation. One of them, obviously, is the importance of culture, the importance of community, the importance of building trust, and also I think the importance of just starting. Because if we have this, and obviously data, lastly, actually, because if we have all this if we think actively about all those, I would say, factors, it will help with either starting at a micro level for entrepreneurs who are out there who are looking to help with the public health in Africa. And even if one or two people happen to be in the public space where it comes to policy making, it will also be helpful to think of these factors. So just to quickly recap for those watching later, it's clearly community, it's clearly trust, it's clearly data, and it's also getting the right culture fit for what you're working on. As we go towards the end of the conversation, I would like to ask a question about trends, because in your last answer, you mentioned obviously it's trending towards the fact that given the potential that's been seen in Africa, investor funding is increasingly available if you look in the right places, if you're lucky enough to be in a community and etc., in a university, etc. Are there trends you're seeing for specialist healthcare? Are there things that I know obviously that MedAtlas and you do quite some work in fertility, but away from maybe fertility, are there other trends you're seeing that indicate the kind of healthcare that people will be seeking in the next couple of years?
Yes, absolutely. A big one is going to be mental health. Um, the, 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 the impact of the pandemic, I think we're going to see for a long time. Many different countries obviously addressed it in different ways, but I'll say, for instance, in Uganda, students did not go to school for 2 whole years, right? And so they were exposed to a lot during that time. And we are one, what's going to be the value of education, what's going to be a lot of teachers, for instance, left schools and are not coming back. So even the infrastructure is changing. So I think grappling with everything that's happening in the world, mental health is going to be a key issue. When there's a shooting in America, all of us are impacted by it. All our emotions are rattled by it. So it's no longer my neighbor had something bad has happened to my neighbor, and now we're all struggling with that. It means that something happening in Ukraine is affecting the mental health of someone in South Africa. So we are so connected that we're going to need more help navigating the amount of information and emotions that's coming up to us from different parts of the world. Another thing that I think is going to be a major issue is um, cardiovascular disease, diabetes, those sorts of lifestyle conditions, because we're no longer going to the farms to dig all day. That's a Ugandan example of historically how people spent their lives. So there was a lot of physical activity. If we're using digital technology, a lot of us are sitting in front of the computer to learn. It also means that the type of food we're eating might no longer be organic or good for us. So those sorts of lifestyle conditions are going to be more and more prevalent, which ultimately normally leads into cancers, kidney failure, those sorts of conditions. So governments moving forward need to think about And this is something we're working on right now, what's called frugal innovation. So low cost ways of ensuring that people can diagnose at home, for affordable, just like we had the COVID rapid test, and people can take that home and test themselves and then decide whether or not to go to the pharmacy. I like that pharmacies are now doing deliveries, right? So that means that they're improving access to healthcare. So simple diagnostics, treatment options also need to be more affordable. So I know for a lot of existing treatment protocols in North America for these diseases that we're now starting to see, there's a whole group of researchers that are thinking about how to make those low cost. And so for those of us, in the research space or who are interested in innovation, this is a good space to start thinking about how people can diagnose at home, treat at home, natural remedies. A lot of people are now moving away from what you call your biomedical treatment forms. They want more natural remedies because, for instance, if your issue is obesity, which is growing in Africa, if your issue is obesity, back in the day, they'll say maybe go for a surgery to address that. But people now are really more interested in more natural ways of doing that, whether it's through exercise, whether it's through going back to organic eating and so on, because all these procedures have side effects, all these medications also have side effects, and people are looking beyond that now. So I think the non-communicable diseases, there are quite many, to be honest, but I see those, the mental health and high blood pressure, diabetes, obesity, those sorts of debilitating diseases growing. Having said that, we're also now having an aging population. People are living longer than before. So that means innovation in aging, how we can improve the quality of life as we get older, is also going to be an important space to think about. People are living now up to 80, 90, and so on. So how can we ensure that they have a good quality of life as we are encouraging them to live longer?
Thank you so much. I was taking quite a lot of notes there because that was really really quite well said. I think if we had to do like a step by step of the logistics of universal health coverage, from our discussion, I think what you've said has really put it into perspective. So what I would like people to take away from this is, one, we get the data right, like we said before. We get the culture and community right, find out what the people want and work from there out. We build trust, which is very important because that's the only way we'll get a healthcare coverage that people can actually use, because if it's there and people don't trust it, they won't use it. And then, like you mentioned in your last answer, frugal innovation is something that we really have to put into perspective. And I think technology has come up quite a lot in our discussion. So how do we use technology? Because the two sides of the coin came out clearly in your last answer, that while obviously technology helps, like WhatsApp, being able to reach people, like USSD, being able to pay easily and all that, there's also the other side of the coin, which is obviously misinformation, which is obviously also the fact that we are so connected with the world around us through technology. It means we are basically bombarding ourselves with things that will hurt us in the long run, because we are so connected with what's happening outside our immediate environment. But these are all quite clear factors that we have to put into place if we're considering.
Chika, I just wanted to add one note on the
Yeah.
technology aspect. A big thing that I am also very cognizant about is the ability of technology to create greater healthcare inequities. So we really want to be cognizant about that while we're, yes, encouraging quite a number of things to move to technology because of ease, we are making sure that we are bringing everyone along and not creating greater inequities. And so from a policy level, that means that access to the internet needs to be a human right at this point if it's going to impact the quality of healthcare or your ability to access healthcare. You know, the type of information that is put up on the internet, more work needs to be done to censor it, or to to put some sort of disclaimer to naive people who might be on there. So we don't want this good innovation to now create greater healthcare disparities that we already have. So I just wanted to point that out as well.
Thank you so much. That's also quite clear because if everyone is thinking of new ways to use technology and there are people who don't have access to it at all, then we are creating a larger gap between those who are able to have access to healthcare and those who don't. Because we are coming up on the 1 hour mark, I think I have a final question and then I will just take your final thoughts. And it's around MedAtlas specifically. Where do you see, because I obviously know that your MedAtlas is expanding. So just talk to us about what countries you currently are in, what countries you're looking to expand to in the next 5 years, and where you basically see MedAtlas in the near future.
That's a good question. So right now, I would say are fundamentally based in East Africa. But I always tell folks that I base that on our specialists, but they see patients from all over the continent, and even we've been very quite surprised with a lot of patients from the diaspora who just want to speak to culturally competent clinicians, right? And also for men, this has been fantastic because I think in African culture, men seeking healthcare has always been seen as weak. And so there's been historically a barrier for men seeking healthcare. And so I'm really glad that in terms of demographics, I think that MedAtlas is really bringing men into this healthcare conversation. We want to certainly go south and west. That's where our partners are. And so, and culturally speaking, I think quite similar. So we see that being our next move. But what the challenges that we are facing as a continent are the same challenges that Latin America faces, that East Asia faces, all low and middle income countries around healthcare. So we see the success of our model being able to replicate in other developing contexts. And that's something that we would be really excited about.
Sounds awesome. Thank you so much. And I think I'm personally rooting for the growth of MedAtlas because it's doing quite important work. And this is where we're drawing the curtain on this conversation. There's been a lot to learn on the logistics of universal health coverage. We will be putting together a communique at the end of the festival with all the lessons and kind of action points because I think, for example, your point on creating data is something I think someone out there might be able to solve. Someone might take that as their own startup, creating the right data for healthcare for in Africa. So we will be putting together all the points we've drawn from this conversation, and hopefully it will spark some very important action. Are there other things you'd like to share with us before we call it a day?
I think, like you said, this has been a quite an expansive conversation, and I appreciate the Engage Africa Foundation really thinking about what are the logistics of universal healthcare? Is it even possible? And so, what my, I guess, 2 cents to that is we need to really define what universal means, right? Because universal means it cannot be the same for everyone because that creates again inequities, right? So saying that, oh, everyone can go to a national hospital and get and deliver for free sounds like universal healthcare, but you need to backtrack and think transportation, how trust, like we talked about. So whilst we're saying universal, what that really means is that we need to get down to the individuals and understand what the barriers are in terms of them accessing what is even currently available. We might not even want to build on yet, but understand that if we already have services that are available and some folks are not accessing them, what's the reason for that? And deal with those issues as we build onto the infrastructure. So universal does not mean the same for everyone. We're all unique, and so that needs to be taken into account.
So that's a really good point for us to end on. Thank you so much, Margaret, for sharing your time with us. And we look forward to future conversations. And thank you very much for everyone who's watched this. Do take care.